Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
Welcome back, everybody, for another deep dive.
Yeah.
This time we're tackling a topic that's as crucial as it is complex. Traumatic brain injury, or TBI for short. We're going straight to the source for this one, using the American College of Surgeons Trauma Quality Programs.
Okay.
Best Practices Guidelines for Traumatic Brain Injury.
Yeah.
Copyright 2024.
All right.
And you can find this online if you want to follow along.
Okay.
I get this. You might be surprised to learn just how common TBI is.
Yeah,
And decisions made in those first few hours can make all the difference.
absolutely. As an emergency room physician, I can tell you firsthand that those initial actions, they really can have a ripple effect that lasts a lifetime.
Oh, wow.
I've seen patients who, because of swift and proper care, were able to regain their lives after a TBI.
Amazing.
On the other hand, I've also seen those devastating consequences when those critical first steps weren't taken.
Oh, that's tough. That really underscores the importance of understanding this.
Yeah.
So before we dive into the intricacies of management, let's start with the basics.
Okay.
What exactly is a TBI?
So a TBI, it's more than just a bump on the head.
Right.
It's a disease process that affects the brain due to an external force.
I see.
We're talking about a blow, a jolt, a penetrating injury,
Wow.
anything that disrupts the normal function of the brain
Got it.
and the impact. Well, it's not just about the immediate injury.
Right.
TBI can have long-term consequences requiring ongoing follow-up and management.
Yeah, so true.
It's a significant public health issue with staggering numbers of emergency room visits and hospitalizations each year.
Wow, those numbers are eye-opening. Okay, so let's say someone arrives with the suspected TBI.
Okay.
What happens first?
So speed is key.
Right.
We need to assess the situation rapidly and figure out the best course of action.
Okay.
Now, for anyone with the suspected TBI, rapid transport is paramount,
Got it.
especially to a trauma center with neurosurgical capabilities.
To the right facility as quick as possible.
Yes.
Are there any specific criteria that would necessitate that immediate transfer?
Absolutely. If someone has a Glasgow Coma Scale motor score below 6, we know it's serious.
Right.
Same thing goes for visible skull deformities, signs of a basilar skull fracture, or any penetrating head injuries.
Oh, wow.
These are all red flags that tell us this person needs specialized care and fast.
What about situations like in rural areas where getting to a trauma center right away just isn't possible?
Yeah, you bring up a really important point. In rural settings, we sometimes face the challenge of long transport times.
Yeah.
So in those cases, initial resuscitation at a non-trauma center might be unavoidable.
Okay.
But even then, having predefined transfer protocols in place is crucial.
Got it.
We need to stabilize the patient as best as possible and get them on their way to that higher level of care.
That makes a lot of sense. Now, what about when it comes to children? Are there any specific considerations for managing potential TBI in younger patients?
So children are, well, they're a whole other ballgame. Ideally, we want to transport any child with suspected TBI to a pediatric-capable trauma center, particularly if we suspect a severe injury. However, we also know that not every bump on the head requires a trip to a specialized center.
Right.
That's where the PCARN guidelines come in.
Oh.
PCARN stands for Pediatric Emergency Care Applied Research Network.
Okay, so PCARN helps you determine when that transfer is absolutely necessary.
Exactly. These guidelines provide us with evidence-based criteria to help us decide which children truly need that higher level of care.
I see.
For example, if a child has a minor head injury and meets certain low-risk criteria according to PCARN, a period of observation might be enough.
So it's all about making those informed decisions based on the individual child's presentation.
Right.
Okay, so we've triaged, we've transported. What comes next?
The next critical step is assessment.
Okay.
We need to get a clear picture of the patient's neurological status.
Right.
And for that, the Glasgow Coma Scale, or GCS, is our go-to tool.
Okay.
Yeah.
The GCS is something I've heard about, but to be honest, I'm not sure I fully understand it.
Okay.
Can you break it down for us?
Okay, so think of the GCS as a standardized way to evaluate a person's level of consciousness.
Okay.
It looks at 3 key areas: eye-opening, verbal response, and motor response.
Got it.
And we assign a score to each of these areas, and then those scores are added up to give us an overall GCS score.
Okay.
The lower the score, the more severe the brain injury.
So it's not just about the total score, but about paying attention to each individual component.
Precisely. Each component tells us something different. For instance, a low score in motor response might indicate a more severe injury impacting those brain areas responsible for movement.
Oh, I see.
We document each component separately, not just the sum, because that detailed information is crucial for clear communication among healthcare professionals.
Got it.
Standardized assessment ensures that everybody is on the same page.
That makes sense. Consistency and clarity are key, especially in these time-sensitive situations.
Yes.
So how do you actually use the GCS when you're assessing a patient? What does that look like in practice?
We start by observing the patient. What are they doing spontaneously? Are their eyes open? Are they moving their limbs? Then we introduce stimuli, first verbal,
Okay.
then, if needed, physical.
Got it.
We might use a gentle pinch or pressure on certain points to elicit a response.
I see.
The key is to start with the least invasive and escalate only as needed, documenting the patient's responses every step of the way.
So it's a systematic approach, moving from observation to increasingly stronger stimuli to really gauge their level of responsiveness.
That's fascinating. Now, is the GCS the only tool used in assessing a TBI patient?
The GCS is essential, but it's not the whole picture.
Right.
Another crucial assessment, especially in those first critical hours, is checking pupillary reactivity.
Okay.
This tells us a lot about the brain's condition.
Pupillary reactivity, you mean how their pupils react to light?
Exactly. And it's not just about whether the pupils constrict. We're looking at the size, the shape, and the symmetry of the pupils.
For example, a unilateral unreactive pupil, meaning one pupil doesn't constrict in response to light, can indicate a mass lesion pushing on the brain.
Wow.
On the other hand, fixed and dilated pupils, meaning they're large and don't react at all, often suggests a poor prognosis.
Yeah, wow. It's amazing how much you can learn just by looking at the eyes. It sounds like you're piecing together a puzzle, using all these different clues to understand the extent of the injury.
That's a great way to put it. We're gathering information from every source we can.
Right.
And sometimes those sources need to be more advanced.
Okay.
In older adults, for example, pre-existing conditions can make GCS and pupillary assessments more difficult to interpret.
Yeah.
That's when we might turn to quantitative pupillometry.
Quantitative pupillometry, that sounds pretty high tech.
It is, but it provides incredibly valuable information.
Yeah.
It uses a special device to measure pupillary responses with much greater precision than our eyes alone. This is particularly useful when factors like opioid use, which can also affect pupil size, might complicate our clinical assessment.
So you're basically getting an objective measurement of pupillary response, even when things aren't so clear-cut clinically.
Exactly. It's all about gathering as much data as possible to make the most informed decisions for the patient.
Okay, we've talked about triage, transport, and assessment.
Yeah.
What's next on the TBI management checklist?
Imaging is crucial.
Okay.
And when it comes to TBI, the head CT scan is our workhorse.
I was hoping you'd say that. The CT scan seems like it's become almost synonymous with head injuries.
Yeah.
Why is it so important in this context?
So the CT scan is incredibly fast and sensitive, making it perfect for the emergency setting.
Right.
We can quickly rule out or confirm things like skull fractures, bleeding within the brain, and swelling. It gives us a detailed snapshot of what's happening inside the skull.
So if someone comes in with a suspected head injury, do they automatically get a CT scan?
Not everyone, no. We follow guidelines developed by the CDC and the American College of Emergency Physicians, or ACEP.
Okay.
These guidelines take into account factors like loss of consciousness, post-traumatic amnesia, the GCS score we talked about earlier, and the patient's age.
So if someone loses consciousness after hitting their head, that's a pretty clear indication for a CT scan, right?
Absolutely.
Okay.
But age is also a big factor.
Okay.
Anyone over the age of 65, even with a seemingly minor head injury, will likely get a CT scan.
Okay.
Older adults are more vulnerable to complications from head injuries, so we err on the side of caution.
Makes sense. Now, you said the CT scan can help rule things out or confirm them?
Right.
Does that mean a negative CT scan means there's definitely no TBI?
It's not quite that simple.
Okay.
While a CT scan is excellent for detecting many types of brain injuries, it's not perfect.
Right.
Sometimes we might need to go a step further with an MRI.
An MRI. So when would you opt for an MRI over a CT scan?
An MRI is much more sensitive, especially when it comes to detecting subtle injuries like microhemorrhages, which are tiny areas of bleeding.
Okay.
These might not be visible on a CT scan, but they can still have significant consequences down the road.
So the MRI can pick up on things that the CT might miss.
Exactly.
What about imaging for children? Is the approach the same?
For children, we have specialized guidelines like the PCARN guide we talked about earlier.
Right.
This helps us make informed decisions about imaging, weighing the potential benefits against the risks of radiation exposure. Even if PCARN predictors suggest a CT scan, we might choose to observe a child for a short period, especially if their GCS is 15, indicating a mild injury.
Right.
It's all about carefully balancing those factors.
So you're always taking into account the individual patient's presentation and using these guidelines as a roadmap, but not necessarily a rigid rule book.
Right.
That makes sense. Now, I've heard that there's a new development in TBI assessment, blood-based biomarkers.
Oh, yeah.
Tell me more about that.
Blood-based biomarkers they're incredible.
Yeah.
Think of them as messengers in the blood that can tell us if there's been damage to the brain.
Wow.
They can help us make more informed decisions about who needs a CT scan and who might be able to avoid it,
Okay.
potentially reducing unnecessary radiation exposure.
That sounds like a huge step forward.
It is.
Can you give us some examples of these biomarkers?
Some of the key players are GFAP, UCHL1, and S100B.
Okay.
Each of these proteins is released from damaged brain cells, and we can measure their levels in the blood.
So if these biomarkers are elevated, that suggests there's been some degree of brain injury.
Exactly.
Right.
And not only can they help us rule out the need for a CT scan in certain cases,
Right.
but they can also give us an idea of how severe the injury is,
Yeah.
and even predict how well someone might recover.
Wow. So you're getting a much more detailed picture of what's happening in the brain than you would with just a CT scan alone.
Exactly. And that information is invaluable. For example, S100B, while not FDA cleared for use in the US, is already being used in Scandinavian countries to guide brain CT imaging decisions.
So different parts of the world are adopting these new technologies and incorporating them into their practices based on the latest research.
Yeah.
That's fascinating.
Yeah.
What about GFAP and UCHL1? I'm curious about those.
GFAP and UCHL1 are FDA cleared in the US, and they're proving to be incredibly useful.
Yeah.
They can be measured in the blood within hours of the injury and have an excellent negative predictive value for ruling out traumatic intracranial hemorrhage.
Hold on. Negative predictive value. For those of us who aren't medical professionals, can you explain what that means?
Sure. Essentially, it means that if these biomarkers aren't elevated, we can be very confident that there's no bleeding within the brain.
Okay.
So we might be able to avoid a CT scan altogether, sparing the patient unnecessary radiation exposure. And get this, the levels of these biomarkers on the day of the injury can actually predict how much structural damage there is to the brain.
So you're not only determining if there's bleeding, but also getting a sense of the extent of the injury. That's incredible.
It really is. This is a game changer.
Yeah.
It's allowing us to make more informed decisions about patient care, and it's opening up new avenues for research and treatment.
So we've covered a lot of ground here, from the importance of rapid transport and thorough assessments to the exciting world of blood-based biomarkers.
Yes.
It's clear that managing a TBI isn't just about treating the initial injury. It's about understanding the potential long-term effects and taking steps to minimize them.
You're absolutely right. TBI is a complex journey, but the more we understand, the better equipped we are to guide patients and their families through it.
And that's what it's all about, ensuring the best possible outcome for everyone affected by this challenging condition.
Yes.
Before we move on to the next part of our deep dive, any final thoughts for our listeners out there?
Remember, TBI is more common than you might think.
Right.
By understanding these best practices, you can be an advocate for yourself or your loved ones, helping to ensure that the best possible care is received. Knowledge is power.
Great advice. And for those who are ready to learn more, we'll be back soon with part 2 of our TBI deep dive. Stay tuned.
So what's fascinating about the evolution of TBI management is that we're moving towards a more personalized approach.
Oh, that's interesting.
It's not a one-size-fits-all situation. We're tailoring treatment to each individual's specific needs.
I'm definitely seeing that theme emerge.
Yeah.
It's about recognizing the uniqueness of each case and responding accordingly. So speaking of tailored treatment, let's talk about one of the cornerstones of TBI management.
Okay.
Maintaining those crucial physiological parameters.
Absolutely. We're talking about things like blood pressure, oxygen levels, blood sugar.
Okay.
All those vital signs that keep the body running smoothly.
Okay. But why are those so critical specifically in the context of a TBI?
Because a brain that's already been injured is incredibly vulnerable to further damage. Think of it like this. The initial injury, it sets off this cascade of events that can create a domino effect. If we don't intervene to maintain those physiological parameters, Well, those dominoes can start falling, leading to more brain damage, impacting recovery.
So it's not just about addressing the initial injury, it's about preventing further harm by keeping everything in balance.
You got it. We call this goal-directed treatment, and it's all about targeting our interventions to address specific physiological disruptions. For example, let's take blood sugar.
Okay.
We know that both high and low blood sugar can be detrimental to a TBI patient.
So you're not just treating the brain injury itself, you're also managing all these interconnected factors that can influence how well the brain recovers.
Precisely. Everything's connected. We're constantly monitoring, adjusting, trying to keep everything in that Goldilocks zone, you know.
Right.
Not too high, not too low, just right.
Okay. So blood sugar is one example.
Mm-hmm.
What are some other physiological parameters that you're paying close attention to?
We also keep a close eye on electrolytes,
Oh.
particularly sodium levels.
Okay.
Hyponatremia or low sodium can be a real problem
Okay.
because it can worsen cerebral edema, which is swelling in the brain.
So preventing that swelling is key.
Yeah,
And that means keeping those sodium levels in check.
exactly. And then there's temperature. Fever can be incredibly harmful to an injured brain.
So you're not just letting a fever run its course in a TBI patient.
Not at all. We treat fever aggressively using medications and sometimes even cooling techniques to maintain normothermia, which is that ideal body temperature range.
Got it.
We're essentially creating a protective bubble around the brain,
Yeah.
shielding it from their secondary insults that could make things worse.
It sounds like you're creating the optimal healing environment both inside and outside the body.
That's a great way to think about it. And another crucial aspect of that environment is managing intracranial pressure, or ICP.
Okay. ICP. I know this is a big one in TBI, but I'll admit it's a bit of a mystery to me. Can you demystify it for us?
Okay, so picture this. The skull is like a closed container,
Okay.
and inside that container you have the brain, blood, and cerebrospinal fluid all sharing that space.
Right.
ICP is the pressure within that container.
Got it.
When there's swelling or bleeding in the brain, the pressure inside that container increases.
And that's a problem.
Because if that pressure gets too high, it can restrict blood flow to the brain,
Okay.
essentially cutting off its supply of oxygen and nutrients. It's like squeezing a garden hose. The water can't flow freely,
Right.
and in severe cases, increased ICP can even cause parts of the brain to shift or herniate,
Wow.
which can be life-threatening.
So monitoring ICP is crucial, especially in those more severe cases.
Yes.
How exactly do you do that? Is this where those bolts in the head come in?
That's one method, yes. It's called an external ventricular drain, or EVD. It's a catheter that's surgically inserted into the ventricles of the brain, those fluid-filled spaces within the brain.
Right.
The EVD allows us to continuously monitor ICP and even drain excess cerebrospinal fluid to help reduce that pressure.
So it's both a monitoring tool and a treatment tool.
Exactly. We can also use something called an intraparenchymal transducer, which is a sensor inserted directly into the brain tissue to measure ICP.
Okay.
This method doesn't allow us to drain fluid,
Got it.
but it gives us a direct reading of the pressure inside the brain.
So when do you decide that ICP monitoring is necessary? Is it for every TBI patient?
Not necessarily. It's typically reserved for patients with severe TBI,
Okay.
those with a GCS of 8 or less, especially if their initial CT scan shows signs of structural damage or bleeding.
Right.
We want to keep a close eye on that pressure.
What about patients with a higher GCS score? Would you ever monitor their ICP even if they're not considered severe?
Absolutely. There are definitely situations where we might opt for ICP monitoring even if the patient's GCS is above 8. For instance, if someone has a significant brain injury and is at high risk for things getting worse,
Okay.
we might monitor their ICP even if they're initially stable.
I see.
Or if they have other injuries that require surgery or treatments that could potentially increase ICP, we might choose to monitor to make sure things don't get out of hand.
So it's a judgment call, taking into account the individual patient's presentation and all those other factors that could come into play.
Exactly. And it's not just about monitoring ICP in isolation.
Okay.
We need to consider it in conjunction with other factors like blood pressure
Right.
to get a complete picture of what's happening inside the skull.
You mentioned blood pressure. What's the connection there?
There's this concept called cerebral perfusion pressure, or CPP.
Okay.
It's essentially the pressure gradient that drives blood flow to the brain.
Okay.
We calculate CPP by subtracting the ICP from the mean arterial pressure, which is a measure of blood pressure.
So if blood pressure drops too low, that means less blood flow to the brain, which is bad news, especially when the brain is already injured.
Exactly. That's why maintaining adequate blood pressure is so crucial in TBI. We want to ensure that CPP stays within a healthy range to support brain recovery.
So there's this intricate dance between managing ICP and blood pressure to optimize brain perfusion.
You got it. And that's where things can get tricky because some treatments for high ICP, like certain medications, can actually lower blood pressure.
Oh, wow.
It's a constant balancing act requiring careful monitoring and adjustments.
This is where the expertise of you and your colleagues really comes in. It's not just about following a protocol, it's about understanding the nuances of each case and making those real-time adjustments.
Absolutely. We're constantly evaluating, reassessing, and fine-tuning our approach based on the patient's response.
Okay, so we've talked about managing those crucial physiological parameters, including the delicate balancing act of ICP and blood pressure. Let's move on to another area where specialized knowledge is crucial, surgical management of TBI.
This is where things can get, well, a bit more intense.
Yeah, but it's important to remember that surgery isn't always necessary in TBI.
Okay.
In fact, many patients can be managed medically without needing to go under the knife.
So when IS surgery indicated in TBI, when do you make that call?
The most common reason for surgery is to evacuate a hematoma, which is a collection of blood that's putting pressure on the brain.
So if there's bleeding in the brain, surgery can help relieve that pressure and prevent further damage.
Exactly.
Makes sense. Now, I know there are different types of hematomas.
Right.
Can you walk us through those?
Sure. So the two main types we see in TBI are epidural hematomas and subdural hematomas.
Okay.
An epidural hematoma occurs between the skull and the dura mater, which is the outermost layer of the brain.
Okay.
A subdural hematoma, on the other hand, occurs between the dura mater and the arachnoid mater, which is the middle layer of the brain's protective coverings.
And these different locations require different surgical approaches?
They can, yes.
Huh.
Epidural hematomas are often treated with a craniotomy. A craniotomy, that sounds pretty serious.
It is a significant procedure, but it's also a very precise and controlled one.
Okay.
Essentially, we create a temporary opening in the skull,
Okay.
remove the hematoma, and then replace the bone flap.
So they're literally lifting up a flap of the skull to access the brain.
That's right. It might sound dramatic,
Yeah.
but it's often the best way to remove those epidural hematomas and relieve the pressure on the brain.
Got it.
Subdural hematomas, on the other hand, can be a bit more complex.
Correct.
They might require a larger craniotomy,
Okay.
or in some cases, a decompressive craniectomy.
Decompressive craniectomy, that sounds even more intense.
It is a more aggressive approach.
Okay.
In this procedure, we remove a portion of the skull and don't immediately replace it. This creates more space for the swollen brain and helps to reduce pressure.
So it's like giving the brain some breathing room, literally.
Yeah.
When would you choose this approach over a craniotomy?
We typically reserve decompressive craniectomy for cases where the brain swelling is severe, and other measures, like medications, haven't been successful in controlling ICP.
Right.
It's a life-saving procedure in many cases.
I can see why it's reserved for those more critical situations.
Yeah.
Now, is surgery always about removing hematomas, or are there other reasons you might operate on a TBI patient?
Sometimes we need to surgically address other issues,
Okay.
like a depressed skull fracture, where a piece of the skull is pushed inward and might be pressing on the brain.
I see.
Or we might need to remove a blood clot that's blocking blood flow to a certain area of the brain.
So the decision to operate and the type of surgery you perform, it all depends on the specific injury and the overall clinical picture.
Right.
It's not a one-size-fits-all approach.
Exactly. And just like with any surgery,
Right.
there are risks and benefits that need to be carefully weighed.
Of course.
We always involve the patient's family in these decisions,
Right.
explaining the options, making sure they understand the potential outcomes.
So it's a collaborative decision-making process.
Yeah.
Bringing together the expertise of the neurosurgeons, the trauma team, and the patient's loved ones.
Yeah.
It takes a village.
It truly does.
And I imagine there are ongoing advancements and innovations in surgical techniques for TBI.
Absolutely. This is a field that's constantly evolving. New techniques are being developed all the time, using minimally invasive approaches whenever possible,
Right.
with the goal of minimizing risks and maximizing recovery. It's an exciting time to be in this field,
Yeah.
knowing that we're constantly pushing the boundaries of what's possible.
That's what it's all about, finding new and better ways to help our patients heal. Now, we've covered a lot of ground here,
Yes.
from maintaining vital signs to the complexities of surgical intervention.
Right.
But there's another aspect of TBI management that we haven't touched on yet,
Okay.
and it's one that often surprises people. Nutritional support.
Yeah.
Nutritional support. I wouldn't have immediately thought of that as a key element in TBI management. Right. Why is nutrition so important in this context?
Because TBI patients are in a hypermetabolic state,
Okay.
meaning their bodies are working overtime to heal.
Right.
They need more calories, more protein, and more nutrients than usual to fuel that recovery process.
So it's not just about giving them any food, it's about providing the right kind of fuel for their body to repair and rebuild.
Exactly. And here's the catch. TBI patients often have difficulty eating or swallowing due to their injuries.
Oh, wow.
So we need to find alternative ways to provide that essential nutrition.
Okay, so what are those alternative methods? How do you ensure that these patients are getting the nutrients they need?
So the preferred method is enteral nutrition, or EN.
Okay.
This involves delivering liquid nutrition directly into the stomach or small intestine through a feeding tube.
So bypassing the mouth and esophagus altogether.
Right. This allows us to deliver a controlled amount of calories and nutrients,
Okay.
even if the patient can't eat normally.
When do you typically start EN?
As soon as the patient is hemodynamically stable, meaning their blood pressure and heart rate are stable,
Okay.
ideally within 24 to 72 hours of the injury.
Wow.
And we aim to achieve full nutritional supplementation within 7 days.
So you're not wasting any time. You're getting that nutritional support on board as quickly as possible. Now, you mentioned a feeding tube.
Right.
Are there different types of feeding tubes used in this context?
Yes, there are. The type of tube we use depends on the patient's individual needs.
Okay.
If they're at high risk for aspiration, meaning food or liquid entering the lungs, we might opt for a post-pyloric feeding tube,
Okay.
which bypasses the stomach and delivers nutrition directly into the small intestine.
So it's about minimizing those risks and finding the safest and most effective way to provide that nutrition.
Exactly. And if for whatever reason EN isn't possible,
Right.
we might need to use parenteral nutrition, or PN.
PN. That sounds familiar. Is that where they're getting nutrients directly into their bloodstream?
You got it. It involves delivering a specially formulated solution of nutrients
Wow.
directly into a vein.
Okay.
It's not our first choice because it bypasses the gut,
Right.
which plays an important role in digestion and immunity.
Right.
But it can be a lifesaver when EN isn't an option.
So it's a backup plan, but a crucial one nonetheless.
Yeah.
And when you're talking about nutritional support, you're not just talking about calories and protein, right?
Right. We're also carefully managing blood sugar, electrolytes,
Well.
and making sure the patient is properly hydrated.
So it's a complex balancing act
Yeah.
involving a whole team of specialists,
Yeah.
from dietitians to nurses, working together to ensure that the patient's nutritional needs are met.
Exactly. It's a multidisciplinary approach, all focused on optimizing the patient's nutritional status to support their recovery.
Okay, we've covered a lot of ground here, from the importance of maintaining those vital signs to the intricacies of surgical intervention and the often overlooked but critical role of nutritional support. It's clear that managing TBI requires a holistic approach, addressing not just the brain injury itself, but all those interconnected factors that can influence the recovery process.
You're absolutely right. It's about seeing the whole person, not just the injury. And it's about recognizing that TBI recovery is a journey,
Yeah.
often a long and challenging one
Yeah.
that requires a team effort.
That's a great point. It's not just about the medical interventions, it's about the support, the compassion, and the unwavering belief in the patient's ability to heal.
Absolutely. We walk alongside our patients and their families every step of the way,
Right.
offering encouragement, guidance, and the latest knowledge
Yeah.
to help them navigate this complex and often overwhelming experience.
And speaking of knowledge, we've still got more ground to cover.
Yeah.
Stay tuned for part 3 of our TBI deep dive, where we'll explore even more fascinating aspects of this intricate field. Welcome back to the final part of our deep dive into TBI management. It's been quite a journey so far, hasn't it?
It has. We've delved into the intricacies of rapid assessment,
Right.
explored the world of advanced imaging and biomarkers,
Yeah.
and even ventured into the operating room.
And through it all, one thing has become abundantly clear. Managing TBI isn't just about treating the physical injury.
Yeah.
It's about understanding the ripple effects, the interconnectedness of everything.
That's precisely it. We can't just focus on the brain in isolation. We have to consider the whole person, their physical health,
Right.
their cognitive function, their emotional well-being.
It's about recognizing that a TBI can really shake up a person's entire world.
Right.
And our approach to care needs to reflect that.
Absolutely. And that brings us to an often overlooked aspect of TBI management,
Okay.
the polytrauma patient.
Okay. Polytrauma, what exactly does that mean?
It means that the patient has sustained multiple injuries, not just a TBI. We might be dealing with a head injury along with broken bones,
Right.
internal bleeding, chest trauma, you name it.
So it's like a medical puzzle with multiple layers, each demanding attention.
Precisely. And managing these patients is a delicate balancing act. We have to prioritize life-saving interventions, like controlling bleeding or stabilizing fractures, while also protecting the brain from further damage.
So it's a constant juggling act, trying to address those immediate life-threatening issues without compromising the patient's neurological status.
Exactly. And that often involves a highly coordinated dance between different specialists, trauma surgeons, orthopedic surgeons, neurosurgeons, everyone working together to ensure that each injury is addressed in a way that supports overall healing.
It truly takes a village, doesn't it?
It does. And one of the key challenges in managing the polytrauma patient is deciding when to operate on those other injuries. We have to carefully consider the impact of surgery and anesthesia on the already injured brain.
Right, because those things can potentially increase ICP or affect blood pressure.
Yeah.
Both of which are crucial in TBI recovery.
Precisely. So sometimes we might delay surgery on those other injuries, opting for damage control measures to stabilize the patient until their neurological status improves.
So it's a strategic approach, carefully timing those interventions to minimize risks.
Exactly. And it's not just about surgery. We also have to be incredibly vigilant about preventing complications like infections, which can be more common in polytrauma patients due to their multiple injuries and often compromised immune systems.
So things like meticulous wound care, close monitoring for signs of infection, those are all crucial.
Absolutely. And of course, we're still focusing on all those other factors we discussed earlier, maintaining blood pressure, oxygen levels, blood sugar, all those things that can influence brain recovery.
It sounds like managing the polytrauma patient is a bit like playing a high-stakes game of chess, where every move has consequences.
That's a great analogy. It requires strategic thinking, careful planning, and constant adaptation to the changing needs of the patient.
Now, you mentioned that polytrauma often involves injuries beyond the head.
Yeah.
Are there any specific injuries that you're particularly concerned about in TBI patients?
One that comes to mind is blunt cerebrovascular injuries, or BCVIs.
BCVIs, okay, that's a new one. What are those?
These are injuries to the blood vessels in the neck that supply the brain.
Oh, wow.
They can occur due to the force of impact in a traumatic event, even without a direct blow to the head.
So the impact can kind of ripple up through the body and damage those vital blood vessels.
Exactly. And these injuries can be tricky because they don't always show up on initial imaging. They can develop over time, leading to potentially devastating complications like stroke.
So you're not just looking for those injuries in the immediate aftermath. You're also monitoring for them down the road.
Precisely. We have specific criteria to help us identify patients who are at higher risk for BCVIs. Things like certain types of skull fractures, neurological deficits that don't quite match up with the imaging findings. Those can all raise red flags.
So if someone meets those criteria, what happens next?
We'll often order specialized imaging, like a CT angiogram, which gives us a detailed look at the blood vessels in the neck. And if a BCVI is confirmed, we need to take steps to prevent a stroke.
What do those steps involve?
Well, it depends on the type and severity of the BCVI. We might use medications like anticoagulants or antiplatelet agents to thin the blood and reduce the risk of clotting.
So preventing those clots from forming and blocking blood flow to the brain.
Exactly. And in some cases, we might need to perform endovascular surgery, where we go in through the blood vessels to repair the injury.
It sounds like managing BCVIs requires a high level of expertise.
It does. It's a specialized area, and we often work closely with vascular surgeons who have the skills and experience to treat these complex injuries.
It's amazing how interconnected everything is in TBI. From the brain to the blood vessels in the neck, it's all part of one big system.
It is. And that interconnectedness extends beyond the physical aspects of TBI. We can't forget about the psychological and emotional impact of these injuries.
That's such an important point. It's not just about fixing the physical damage, it's about supporting the patient's mental and emotional well-being.
Exactly. TBI can lead to a whole host of psychological and emotional challenges. Anxiety, depression, PTSD, cognitive difficulties, personality changes, the list goes on.
It's like the injury throws their whole world off balance.
That's a powerful way to put it. And these challenges can have a huge impact on their recovery and their ability to return to their lives.
So how do you address these psychological and emotional needs?
It starts with recognizing that they're just as important as the physical aspects of TBI.
Right.
We screen for these issues early on and make referrals to specialists like psychologists, psychiatrists, and neuropsychologists.
So it's about connecting them with the right resources and support.
Absolutely. And it's not just about the patient. We also need to support their families, who are often going through their own emotional roller coaster as they grapple with the changes in their loved one.
Right. Because TBI affects the whole family unit, not just the individual.
Exactly. And we need to provide education and resources to help families understand what's happening, how to cope, and how to best support their loved one.
It's about empowering them to be active participants in the recovery process.
Precisely. And we need to remember that recovery from TBI is a marathon, not a sprint.
Right.
It takes time, patience, and a whole lot of support.
And that support needs to extend beyond the hospital walls.
Absolutely. We need to ensure that patients have access to ongoing rehabilitation services, support groups, and community resources to help them navigate the challenges of living with a TBI.
It's about creating a safety net that catches them as they transition back to their lives.
Exactly. And on a broader level, we need to advocate for policies and systems that provide adequate funding and support for TBI survivors and their families.
Because TBI is a lifelong journey, and they deserve all the help we can give them.
I couldn't agree more. And that brings me to one final thought.
Okay.
We've been talking about best practices, guidelines, and evidence-based approaches.
Right.
But at the end of the day, the most important thing we can do for TBI patients is to treat them with compassion, empathy, and respect.
That's beautifully said. It's about seeing them as individuals, not just injuries.
Exactly. It's about recognizing their strength, their resilience, and the incredible journey they're on.
It is incredible.
And it's about walking alongside them, offering support and encouragement every step of the way.
What a powerful way to end our deep dive into TBI management. It's been an incredible journey, and I've learned so much from you.
It's been a pleasure sharing my knowledge with you and our listeners.
Absolutely.
And I hope this deep dive has empowered everyone to advocate for themselves, their loved ones, and for better TBI care overall.
I have no doubt it has. To all our listeners out there, thank you for joining us on this deep dive.
Yes, thank you.
Remember, knowledge is power. And by understanding TBI, we can all make a difference.
We can.
Until next time, stay curious.